Now, Paul van Buynder is a public health physician based in Melbourne. He's the past chair of the Immunisation Coalition and professor at the School of Medicine at Griffith University in Queensland. Paul and I go back a long way. He's a fantastic advocate for vaccination in older people in particular, and he's going to talk about plans for improving immunisation rates in adults over 60. He might even mention the M word. Paul.
Thank you, Michael. I admit to a conflict of interest. I turned 70 this year, so obviously this is a fairly important topic for me. Okay, these are my disclosures. And the first thing is, why should we talk about old people? And the first point I want to make is this is not actually the same as paediatric hesitancy. No one aged 70 is worried about how many antigens they're getting. No one is worried about autism or any of the other, key issues. They're not getting vaccinated for different reasons, although trust is obviously still a critically important point. So healthy ageing is not about avoiding influenza. It's the process of developing and maintaining functional ability. Vaccination for old people is the maintenance of functional capacity. I market this as a necessary process in healthy ageing. And people are worried about cognitive impairment. They're worried about living with dementia, and they're worried about frailty. So they want to be able to keep moving and they want to be able to keep thinking. And the rest of it is secondary to those things which dominate discussions about what they consider to be health as they age. And so protecting them from infectious disease is important. They're at risk of several diseases. They don't respond well to treatment, and they suffer high rates of mortality and morbidity. And so at the beginning, I just want to concentrate on vaccination reducing infectious diseases before we talk about the other benefits of that as well. And this is an important concept that I'm sure everybody's pretty well across by this stage. We need a functional immune system as we age, and a functional immune system is less possible at that stage because of the combination of both immunosenescence and inflammaging. And so you spend a lot of your naive T cells converting them to protection against your inbuilt zoster virus, your inbuilt CMV virus, and so on, the concept of inflammaging. And as well as that, from the age of about 14 onwards, as your thymus starts to involute, you start to run out of memory T cells, run out of naive T cells, and you have less capacity to deal with all of these. So you have a decreased response which comes naturally as you age and as you fight off chronic viruses that live in your body. In addition to protecting you from infectious diseases, there's been a lot of reports on the health economic benefit of vaccinating old people, quite apart from the direct impact. Old people look after grandchildren so that parents can go to work. They perform enormously important volunteering processes within the community. And so the comment made by this group, which looked at about a dozen different countries, was that for every dollar you spend vaccinating old people, the community benefit is about 19 times that particular process. So the other additional benefits, and we're starting to understand a lot more about this, even though we're still not clear about the actual pathological benefits at times, they reduce cancers. They reduce dementia, and while we thought that was from data originally from Shingrix, it's also data that now comes out of pneumococcal vaccine, influenza vaccines, DTP and so on, and there was a recent review talking about the 8 different vaccines that were potentially preventing dementia. And there's been a lot of work, including in Australia from groups like Raina McIntyre's, about the prevention of mortality over the next 1 to 12 months from both cardiovascular and cerebrovascular disease if you stop people getting the infectious diseases beforehand. So these are what I consider the required vaccines for healthy ageing: flu, pneumococcal, shingles, pertussis, SARS and RSV as well. And all of them, apart from potentially pertussis, contribute to a loss of capacity. So one of the critical things about getting infected with these as you age is a thing called catastrophic disability. And there are enormously good data that being hospitalised with one of these diseases leads to around 3-step decrease in your frailty index. So people who are looking after themselves at home, not particularly fit, get influenza, go to hospital for a week, and then they are likely to need a nursing home or assisted care facility rather than being able to go back home again. And so it's very important that we deal with this impact on frailty when we look at these. So why are we doing so badly with this? Older persons need to understand the burden of disease. Very few older people that I talk to believe that RSV is something that they should be considering. They don't understand the 100-day cough has significant morbidity and mortality issues. In addition, they need easy access to immunisers, and that's critical for groups like those living in assisted living who can't get out and about. And they need affordable vaccines, and while we are starting to see some improvement, too many of these vaccines are unfunded for older people. On top of that, we need to use the best available vaccines amongst the broad spectrum of vaccines that we've got on our thing. So how are we doing? Influenza's running at 61%. I can remember when it was 75 to 80% in this particular age group. People just turned up and got their flu shot. No increase at this stage from last year, and so far we're tracking a little behind. 30% is now given in pharmacy, but what we've managed to do is actually swap provider, not increase the amount of vaccine that we're giving. Pneumococcal vaccine's running at about 45%. I'm hoping for a great improvement with the simplification of the program and PCV 21 being available in 2 weeks' time. It sounds better than it really is. You've got to remember that people who get vaccinated are then vaccinated from then on, unlike people who get a flu shot who need another one. So that 45% includes everybody who had pneumococcal vaccine ever since they turned 65. COVID coverage is terrible. And for the unfunded vaccines, RSV is really too early to say how we're doing with older people. Pertussis runs at less than 10%. And so we saw some data about the COVID coverage and how bad that is, but really we're just doing poorly when it comes to each of these, despite the fact that some of these are funded vaccines. So how do we fix it? This is a slide that you've already seen today that was lent to me by Jess Kaufman. It's the WHO process. I want to focus for older people on the green bit to some extent. The health worker recommendation for these vaccines is largely absent from these. There are very, very few paediatricians or general practitioners who don't recommend childhood vaccines, with the exception of influenza, whereas there are large numbers of general practitioners and gerontologists and specialists who don't get around to discussing the importance of vaccination at all. These next two are a series of articles that were written by Michael Woodward, John Litton, myself, a couple of years ago now, who looked at how to improve vaccination uptake in older people. First is we need to develop an awareness. If you don't believe flu is bad for you, if you don't believe RSV is bad for you, then you don't see the need to go out yourself and get it. So we need to actually advocate with the public, professionals and government. We need to develop an awareness that these vaccines are both effective and safe, and there's a lot of view about things like flu vaccine as being fairly rubbish. We need to fund the vaccines, and we've still got work to do with that, although we've seen some improvement recently. We need to develop a broad-based program that, again, is starting to improve with pharmacies and nurse immunisers and other health professionals. And we need to have a target. I mean, I don't know what the national target is for the new vaccines that we've introduced, but we certainly need a surveillance system that looks at both coverage by age group and by subgroups of the population, and then look at disease and look at what impact we're having, and then has a capacity to actually change that depending on what the numbers are saying. And so these are the articles that were there. There was a question about how do I deal with this in 10 minutes. As a general practitioner, we used the example of pertussis vaccine, and we said that you really need to have an understanding of what it is that worries them. So people who say, I don't believe in vaccination, you can't deal with that in 10 minutes. But people who are worried about too many antigens, you can deal with in 10 minutes. And people who don't understand that pertussis as a child does not protect them for life or whatever, again, you can deal with. So you need to be across the specific concerns that people have so that you can address them in the time that you have available to you. Okay. The effectiveness and safety of vaccines is critical, and we've had lots of debate about that recently. The AstraZeneca SARS-CoV-2 messaging was poor at the beginning. My mother's 94. She's in an aged care institution. I told her she should get a COVID vaccine when she was about 88. She told me she was waiting for Pfizer. And I said she didn't need to do that, that AstraZeneca was safe. Her comment was, you're a flu person, you don't know anything about this. So similar processes when we spoke to primary care physicians about Zostavax. Our coverage was really poor. It was too confusing. Who should get it, who shouldn't get it? You know, was methotrexate 3 milligrams per kilogram, or what was the dose of prednisolone that you're allowed to have? If they have efficacy concerns, uptake is decreased. Our influenza vaccine, probably in the adjuvanted group in the Aldi runs at a good 60%. PCV7 was 60%, HPV4 was 60%. All of a sudden we've got different guidelines for when we say something's worth having for these. And if you have multiple boosting, then a message that said, please get your COVID vaccine, and then 4 months later, please get the new one, and then 4 months later, you still need to get the new one. I'm up to 13 doses so far. Most people I know have had 2 or 3, and then they've given up with those. So we need to have something that is not going to be needed to be done every few months. The whole issue of older persons aren't as valued as younger people. So we have lots and lots of programs for children and strategies. I agree we need to do something about this dropping just below 90%. I would give my left kidney for 90% coverage in older people for any of these vaccines, which we're not going to do. So we have to articulate the burden of disease more clearly, and that's not just to the public, that's to physicians, primary care practitioners, everybody in the nursing spectrum, because we've got to get them advocating at the time that they see people. A community campaign will not resolve this issue, and we really need to get every single immunisation specialist talking about this and getting whole lots of other groups that I'll mention. We have to identify the key comorbidities, and we've got to share the messages amongst groups. So, first step, we need surveillance at the national level, not just the rate of disease and serotyping, but also vaccine coverages and effectiveness. If you don't know what the problem is, if it's not visible, then you can't fix the problem. We need variations based only on science. So we've got to have a national level policy for these processes. I mean, Australia over the last 10 years sadly has gone from having a very strong program out of the out of the federal government to one that says eventually they'll get round to it if enough states actually pay for it themselves. And so we need to make sure that we're stopping that sort of process that says, look, you can have flu mist, at 11 in Western Australia, at 6 in Queensland, when we finish building a railway line in Victoria and at other ages elsewhere. So, and we need to simplify the process and make them stronger when necessary. And I think PCV 20 and 21 a really good example. I never understood pneumococcal policy in Australia. It was 12 pages of the influenza handbook. I didn't know a single GP who knew about it, and none of them were particularly fussed about the fact that they weren't vaccinating people because they hadn't read the 12 pages. And plus, 4 million people were recommended to get it by ATAGI and in the handbook, and we funded it for about 9 people. I've forgotten the names of those 9, but they had cochlear implants and end-stage kidney disease. So we need to make sure that we're now going to something that is better, and I think PCV 20 for children and 21 for adults is going to make a big opportunity for us to improve coverage rates. We need widespread access, and I think we're doing better, and I'm particularly pleased that pharmacists can now go into aged care and run programs there, and are funded to do that because aged care are often covered by 8 different GPs looking after their own patients, and that goes against having a good program where everybody gets the same. We need aid memoirs, and IC develops a Smart vaccination tool. I know that Angela is going to continue to update that as we bring in new vaccines all the time. She tells me she's quite fit. She's looking forward to doing this for the next 15 or 20 years of her life, which I think is great because this is now going to be much simpler. You can put a person into that, put in their age, their comorbid conditions, what they've had previously, and it will tell you what vaccine to give. And so that means you don't have to learn the 12 pages. You can just go to Smart, and you need availability, equity, and accessibility. And then step 3, and this is critical, you need to have healthcare workers beyond primary care. And so we've been running vaccination masterclasses for geriatricians and specialists. Attendance has been less than I would have liked, and Michael Woodward, who organises these, would have liked, supported by the IC, but we really need lots of stuff happening. One of the good things was the discussion by geriatricians about the common geriatric assessment, the CGA, that everybody gets when they first see a geriatrician. It says in there you must discuss vaccines. We've now got the Kidney Society putting out a guideline saying these are the vaccines for people with kidney disease. The cardiology societies are all getting involved. We actually need people who start providing treatment for comorbid conditions, immunologists who start putting people on Humira and various other JAK inhibitors and others who are going to impact on their capacity to protect themselves. All of them have got to be, if not giving vaccine, and most of them don't have fridges and cold chain capacity and so on, but at least sending a note back to either their primary care physician or giving them a note saying these are free, go to your pharmacy and show them the note, they will give you these. We've got to broaden this beyond, and we need to have specific issues in particular settings. When I was doing a locum at the Aboriginal Medical Service in Swan Hill, my wife did a review. 6% of Indigenous persons in that practice had pneumococcal vaccine, 6% of people over the age of 50, and it was free. A process that changes, so that said that everybody over 50 who turns up first gets air reviewed, and then a note goes on the file when they go to the doctor saying needs 1, 2, 3, 4 vaccines. Increase that to mid-50s by the time we left that. And there's a whole range of other examples that are there from specific areas of need where if you have an automated system saying we need to deal with vaccines, then you can greatly increase vaccination. We can't just rely on primary care. We've got to have specific programs with conditions, and you've got to have hospital-based programs as well. And I know that some of our adult facilities, the Alfred, are looking at specific adult programs rather than the very good program run by places like the Children's Hospital. So this is a great website that if you have a chance to look at it, it's a process that looks at broad-based strategies for vaccinating the elderly for healthy ageing. and has a lot of good information on it. And so to finish up, we need simpler messaging. We've got to convince people that this is important. We need to educate the masses. If they don't understand the importance of these, then something generic about, hey, old people, let's get vaccinated is not sufficient. We've got to go broader than the current groups we're looking at, and we're starting to do that, and I think it's great what we're doing with, the availability of Shingrix, the broadening of access for people for pneumococcal disease. We need better vaccines. The AS01 vaccine have been really important in showing us that we can protect older people. We need some cost and transparency. We need hospital and specialist access. Thank you.
Thank you. Thanks, Paul. We'll next hear Paul at the Melbourne Comedy Festival. He's already lined up, I'm sure. There's a few questions online. Boostrix, would we improve pertussis vaccination if it was funded for people over 65?
Not unless we actually convince people over 65 that they need to be protected against pertussis. And so at the moment, we started with a cocooning strategy that said, hey, you're a grandparent, protect your newborn baby when it comes out, your grandchild. And, we were moderately successful, but not greatly successful at doing that. It's been less of a focus now that we get, anything up to 85% of pregnant women getting pertussis vaccine in pregnancy. And so it's less of a focus, but I don't think that making Boostrix a funded vaccine would do anything unless we convince both primary care physicians and other vaccinators and the people themselves that this is not something that you have in order to make sure that your grandchild doesn't get sick. This is something because the 100-day cough is associated with cracked ribs, with strokes, with a whole lot of other things, and has a defined mortality. And in fact, some studies, I remember the study in the monastery in Belgium, had a mortality rate of 5% when they had a pertussis outbreak go through there. So I don't think older people understand that pertussis is actually a nasty disease for them as well. And I think that's important before, we just look at funding as the solution.
And indeed, it is as infective as measles, which a lot of people don't understand. There was another question about why don't we start setting a target for one disease? Let's say 75% of people get Capvaxive over the next 5 years. Why don't we start?
I think that's an excellent idea. I'm disappointed that Michael's left already, but I think we need to do something. I mean, we cannot accept the sort of figures that we've got. We don't publicise them as well as we do for paediatric vaccines. I mean, we can look at this now and say we've had a 4% drop in this. We're down to 88% at 2 years. We're down to, we don't get to 92% until they're 5. We have to do something. I mean, we have rates of 40%, 30% less than 10% for some of our older persons. I agree. Let's put a target on it and let's have something that says we're going to throw some resources at this and try and do something.
Thanks. There's quite a few more questions, but we'll wait for the panel at the end. So thank you, Paul. Again, hand of applause. And our final of the 3 talks in this session is